further ado, I'd like to introduce you to one of our first speakers for our esteemed panel. It's my colleague, Ms. Barbara Harrison. She is a certified genetic counselor at Howard University. She is also an assistant professor that teaches in the areas of genetics, genetic testing, genetic counseling, and most important, ethics, if we talk about research. She's the Assistant Director for Community Outreach and Education at the Howard University Center for Sickle Cell Disease, and she provides genetic counseling services to Howard University Hospital patients. She received her master's degree in genetic counseling from the University of Pittsburgh, and she also received a certification through the American Board of Genetic Counseling before joining Howard University full-time. She has co-directed their genetic counseling training program, working mostly in pediatric and prenatal genetics, while all along supporting sickle cell research and providing consultation for participants. So without further ado, I'd like to turn it over to Ms. Barbara Harrison. Welcome.
Thank you so much, Vinny, for that wonderful introduction. So yes, I hope to help to orient ourselves to what sickle cell disease is, and then concentrate a little bit on my special corner of it, which is in genetics. And then I'll lead right into the next presentation, which I think will be great. So what is sickle cell? So we know that sickle cell disease involves the red blood cells, and inside of our red blood cells is many different things, but one of the things is something called hemoglobin. And so you can see in this top diagram a picture of red blood cells going through our blood vessels, and then that kind of cut through of a red blood cell with the hemoglobin inside. And so you can see that red blood cells, especially when you get to the very small vessels, and you can kind of appreciate that in the diagram to the right. But as you get to those small vessels, these red blood cells often have to squeeze through one at a time. So they're really quite malleable and soft. And that's what happens when that hemoglobin A is inside. But just like there's different eye colors, hair colors, there are different types of hemoglobin. And so even though the most common type of hemoglobin is hemoglobin A, the next most common type is hemoglobin S, or sickle hemoglobin. Now, sickle hemoglobin is also inside of that red blood cell. It carries oxygen, which is really the job of hemoglobin. However, when it loses its oxygen, it starts to act differently than that hemoglobin A. And specifically what happens is it sticks to other pieces of hemoglobin in the cell. So when we look at the bottom part of this diagram, you can see the cross section of a sickled cell, and you can see those lines through it. So that's indicating these pieces of hemoglobin that are stacked on each other and almost are like rods inside of that cell. And so now this cell, instead of being very mushy, is quite rigid. And so it's hard for that cell to get through those very small blood vessels. And so you can see how they're kind of gathering there, almost causing a clot. This is something that's called a vaso-occlusion, because it's occluding or blocking that vessel. And so this is really the hallmark and kind of bottom line of what happens in sickle cell disease, but the effects of it are quite broad. And again, I will leave that for a discussion a little later. We can go to the next slide. So the way that our body knows how to do anything, to digest our food, to know how tall we're going to be, it's by looking or reading our genetic information, or our DNA. And so for almost all of our traits, we get information from our mom and our dad that tells us what type of whatever it's going to be, eye color, hair color, and so forth. And hemoglobin is no different. And so when we try to think about what causes sickle cell, or what's that genetic underlying cause for sickle cell, we need to go back and look at that genetic information. And so on the left side, you'll see it says here, hemoglobin A from both parents. So if the instruction for hemoglobin A has come from both parents through that egg and through the sperm, then that person will have what we call hemoglobin AA. So this is the most common. Most people who we would test their hemoglobin would have this hemoglobin AA, and they would take oxygen fine and not really have any problems. But on the far right, you will see a person who has inherited hemoglobin S from both parents. So, well, actually, I guess second to the right, I'm sorry, that they've inherited that hemoglobin S from both parents. So they've inherited a hemoglobin S from their mom, an S from their dad. All the instructions their body has is to make hemoglobin S. And so again, they'll make that hemoglobin, they'll carry oxygen, but then that problem can happen that we talked about before. Now, if you inherit a hemoglobin A from one parent and then a hemoglobin S from the other parent, you'll end up in that second slide. And so this is what we commonly call sickle cell trait. And the formal wording for it is being a carrier. And so you can be you're a carrier for sickle cell, meaning that in general, you're healthy, and we'll touch on that in a minute. However, you carry this genetic information for hemoglobin S. Your body actually produces some of that hemoglobin S, but you have enough of that A that it keeps you from really having any complications. But then you can pass that S on to the next generation. And then we know that there are different other types of hemoglobin. There's well over 100 types of variations of hemoglobin. And so you can have those variant types as well, some of which when combined with that hemoglobin S can cause a form of sickle cell disease. Yes, and that's it. Go ahead, as pictured here. So there's different types of sickle cell disease. There's different types of being a carrier, different, you can, have there are a variety of combinations that are possible. And go to the next slide. So I've kind of reviewed a little bit here about how sickle cell disease then is inherited. I think the important point to get from this slide is if you have two individuals that carry a variant type of hemoglobin, again, hemoglobin S is going to be most common, but if they carry that variant type, then the outcomes in their children is going to depend on what information they pass on. And so it's just a 50% chance whether if you have trait, whether you pass on that hemoglobin A or you pass on that hemoglobin S. You can't control it. Nothing too much you can do about that. But we know just by working out the numbers, if there is a couple who both have trait, there is a 1 in 4 chance or 25% chance that their child would actually be born with sickle cell disease. The other kind of 3 in 4 chance is that their child will either have sickle cell trait or possibly just be hemoglobin AA. And so for this couple, yes, there's that 1 in 4 or 25% chance their child will have disease, but there's also that 3 in 4 chance or 75% chance that their child would not. So next slide. So when we are faced with couples who both carry a type of variant hemoglobin, again, sickle cell trait being most common, this is kind of where that genetic counselor steps in, because one of the conversations that I will have with couples is to think about what this means for themselves in the future, and how this might affect their own thoughts about childbearing and reproduction. And so there are different options that I then would talk about with those couples. And so this ranges the gamut. You will have some couples who will look into something called in vitro fertilization or pre-implantation genetic diagnosis. And so this is basically a process where we harvest eggs from mom, we get a sperm sample from dad, we actually create embryos, and then we do genetic testing on those embryos. And so we can identify those embryos that do not have sickle cell disease and choose those to then implant back in mom. Now, I just explained that in a sentence, but please understand that this process is quite involved and quite complicated. And it's also quite expensive. And it not only requires or can take from that couple a financial burden, but also an emotional burden. So this is really something that is there and it's available, but it's not to be taken lightly. And it's not right for all couples, but it certainly is an option that's there. Now, in addition to that, you'll have some couples who may decide to pursue testing while they are pregnant. And so there are options for that, to test a fetus to see if that fetus has sickle cell disease as early as 11 weeks and really throughout the scope of the pregnancy. And of course, people use that information in different ways, whether it's to prepare themselves that their child has this condition. Of course, some couples might choose to end a pregnancy if they find out their child has this condition. It just really varies. And just like with that IVF and pre-implantation diagnosis, these are very complicated and involved decisions. You have some couples that might choose adoption. This is a very open and very available option for some couples. Others may choose to kind of take their chances, recognizing there's that 75% chance that their child will not have sickle cell disease. If a person has sickle cell and they have children with someone with trait, that chance goes up to 50%. But regardless, some couples, after deep conversation, will decide we'll just take our chances. And in those situations, regardless, we test all babies for sickle cell disease at birth. It's part of newborn screening, something that's done regardless of the ethnic background of that child. All babies are tested for sickle cell. And so again, just to emphasize, where a couple lies on this spectrum is very, it's a very personal decision. It's guided not only by, what's just practically available to a couple, but also by cultural beliefs, spiritual beliefs. It's a variety of things that go into this conversation. And that's why genetic counseling is so important, because, sometimes you need help kind of talking through that and really understanding what your options are. Next slide. So just very quickly to say that sickle cell disease and trait, they are common. About 100,000 people in the United States have sickle cell disease, and 1 to 3 million have sickle cell trait. And then specifically on people from that have African ancestry, the chance is higher. So those that are African American have about an 8 to 10% chance, and then people that are more kind of directly from the homeland, from particularly West Africa, can have much higher rates of 1 in 6 and so forth. Next slide. But when we look at that 100,000 people in the United States with sickle cell, we see that about 10% live right here in the DMV. So between the district, Maryland, and Virginia, we house about 10,000 individuals with sickle cell. Next slide. Okay, and sickle cell itself is, we know that it is most commonly found, that gene is most commonly found in sub-Saharan Africa, as well as around the Mediterranean. These are areas that are very high levels of malaria, and we know that individuals with sickle cell trait have a protection against at least death from malaria. So that's kind of how that gene was passed on from generation to generation. It really is protective. Next slide. So running out of time here, so just to run through this very quickly, we know that sickle cell trait generally is a benign condition. Majority of people with sickle cell trait will be healthy, but there are some rare complications that can happen with sickle cell trait. So this is just something to be aware of. If you do have the trait. Again, and I tell people all the time, if you have a problem, go and figure out what it is. Don't say it's just your trait acting up. You need to go find out, if you have problems with your kidneys, go figure that out. But it could be that the sickle cell trait is not helping with that situation. And so I want to end just with talking a little bit about the importance of blood donation. We know that many individuals with sickle cell depend on blood donation, not only for acute treatment, but also just for management of their disease. Some get transfusions as often as every 4 to 6 weeks. And so we need supply to help these individuals live the life that they want to and that they deserve to. But we know that only about 3% of donors are African American, yet African Americans as a whole, about half of us have O positive blood, which is kind of the best blood to give. And in addition, for kind of more complex genetic reasons, those are the African descent. We really have a wide variety within our genetics. And so us giving blood is really what oftentimes works best for individuals with sickle cell disease. So, so just encourage people to do that. Next slide. That's just something very active that we can do, as well as advocating for our friends and family with sickle cell disease, acknowledging things like Sickle Cell Month. So thank you so much for GITVC for doing this talk. And with that, I'm actually going to forward it on to Dr. Taylor. So